Hello, I'm Lawrence Eichenfield, Distinguished Professor of Dermatology and Pediatrics at the University of California, San Diego School of Medicine. Welcome to the first in our Innovations in Dermatology podcast series, Perils and Pitfalls of Pediatric Atopic Dermatitis. And I'm very pleased to have joining me today Dr. Peter Leo. Dr. Leo is Clinical Assistant Professor of Dermatology and Pediatrics at Northwestern University Feinberg School of Medicine in Chicago. Welcome.
Thank you so much for having me.
Well, there's so much that's happening in the field of atopic dermatitis. We've had an incredible amount of information accumulated in the last 10 years that's really shown the impact of atopic dermatitis on affected individuals and on their families. The association of atopic dermatitis with comorbidities, really improved understanding of some of the changes that happen in atopic dermatitis, both variable presentations and variable course of the disease. And probably all of that is dwarfed by the changes in therapies, with both newer systemic therapies and topical therapies that we have in hand and are soon to be in hand as well. That's really helped us to change our practice and I think improve our care of atopic dermatitis. So Dr. Leo and I are going to discuss some cases which are really sort of, I think, explain the sort of practical approaches that we take, both mixing our traditional medicines and newer medicines to help us take care of patients. So without further ado, Peter, I'm going to line up a case for you, okay? This is a 14-year-old who had pretty significant moderate atopic dermatitis as an infant. At that time, it was fairly persistent. It was managed with regular use of general good skin care, frequent moisturizers, and intermittent topical corticosteroids. The family reports that the eczema got much better as a toddler, but for the past year to year and a half, this teen has been bothered by significant atopic dermatitis. So hearing the story, Peter, what's your sense of how you might approach this patient? Again, had early atopic derm, then seemed to be gone or in remission, and now it's back.
First of all, I do feel like we see that J-shaped curve. In other words, they'll have it as an infant, and then they'll have a period of improvement, sometimes many, many years. And then either as an adolescent or an adult, it will come back. And I feel like this is an interesting variant that in some ways is more reassuring to me than the true de novo adult onset where they didn't have any history. But that is interesting in a way. And it makes me think this is probably going to be associated with some more allergies. Dr. Eichenfield, do you find that to be the case too, that patients who have this longer term, more chronic atopic derm, even if they have a period of sort of pseudo remission or even true remission, that they're a little bit more likely to have concomitant allergies?
Yeah, I think so. I know there's not data, but it's impression, and I certainly think longer about that. I guess also from a contact allergy standpoint, I definitely spend some time trying to see if there's an unusual presentation, more regional dermatitis, or there could be some specific provocative factors like allergic contact dermatitis.
Yes, that's such a great point, because if it's just on the hands, for example, then that might take us down one pathway, or just around the eyelids. Then we'd say, okay, maybe there is an environmental contactant. If it's erythroderma, then we're in a whole different group. But I totally agree. I've become an increasing proponent of patch testing for younger and younger patients in the past few years. Historically, I would do it for those patients where I really felt that the yield was high, where this history looks good and the morphology looks good. But increasingly, I feel that there can be contactants in the environment that are, if they're not the underlying cause, which I think in a case like this, I would say if you're a betting person, you're going to lose money if you say, I think this is allergic contact dermatitis is the primary or only issue. But as a secondary confounder, I think they're really common. All of a sudden you say, oh my goodness, you're actually allergic to cocamidal propylbutane, or you're allergic to, propylene glycol. And all of a sudden you realize that half the products we're giving them and they're using are contributing to this atopic dermatitis. If we can identify those and remove those from their environment, many times it takes bad disease and brings it down to at least something that we can control.
Yeah, I want to come back to allergy testing, but before that, I do want to mention that I do see occasional adolescents, predominantly males, but not fully, who've just washed themselves back into eczema. And they're doing this sort of twice a day, long, hot, 20-25 minute shower, often with harsh soaps. And they'll have a follicular eczema presentation, which then sort of gets them revved up again. So that's something just to query in seeing the patients. But Peter, I wanted to ask you, so do you do allergy testing other than patch testing in such a scenario?
So I typically do not. I personally, especially personally in my office, I don't. But for these more chronic patients or patients where I suspect there could be an allergic component, I will often have an allergist involved. I like to say that I think doing blind allergy testing, doing just a big panel of allergens or foods, which we'll get into, of course, because food is often a question that comes up. I feel that it often does more harm than good. So I really like a good allergist to take a little time to ask the right questions and maybe do more specific testing. Now, I often will tell the patients, because a lot of times I think our patients are saying, can you test me for allergies? And I bring up patch testing very quickly, but then they say, well, what about foods and what about environmental things like pollen and mold? And I say, we'll get the allergist involved, but let's be honest. What can we do about that? Many of the patients have crazy high IgE levels, and many of my patients, as I'm sure yours too, have multiple allergies to prick testing or blood testing with IgE, but I don't know how to act on that. I mean, yes, if it's dust mite, fine. We can do some dust mite eradication protocol. But if it's rabbit fur and pollen and mold, you're sort of limited. And then the question is that really actually playing a role in driving the disease? And I'm a little more skeptical of that. So I think it's important to identify them, but it's usually not where the money is, if you will.
Yeah, I agree. I do find that the environmental allergies can be important to the lives of the individuals. So the more severe adolescents, I may send it to the allergist just to have them evaluated, not because it necessarily will trigger their atopic dermatitis. But I was moved. There was a recent paper about some of the big fires that we had in Northern California and how it created a big upsurge in visits for atopic dermatitis at UCSF. When that occurred, it was a clearly discrete example of how environmental influences, in this case, pollution secondary to the fires, triggered a lot of eczema, including patients who showed up just for evaluation of itch without a history of atopic dermatitis. Um, Peter, when do you seek, from a primary care perspective, if they're seeing an adolescent who has active atopic dermatitis, having had a remission, when should they send them in to a dermatologist? Or if it's in the hands of a dermatologist, when would you step up the therapy potentially to systemic therapy?
I really think for our primary care colleagues, there is no stupid consult. There's never anything we're going to laugh at or deride them for. I always try to remind our colleagues that, we often see patients off the street. People come in for screening and things like that. So we're never going to say, boy, that was the wrong move. Always feel free to send in. But specifically, I think in an ideal world, my conception would be that they might try some basic things. So I love that you talked about the washing yourself back into eczema. And I think it's true, especially with the pandemic. We've seen people overwashing using, hand sanitizer to the extreme. And we've seen a lot of dermatitis. So going back to those basics is always important, no matter how severe things look. If they can maybe counsel on gentle skincare, good moisturization, avoiding the known triggers, and then maybe a more reactive approach with a topical corticosteroid if the patient's amenable to that, and starting there. And for the milder patients, that's often enough. Patients are going to say, you know what, I'm okay. I use the steroid for a few days here and there. I'm basically in good shape. We don't need it. But when they come back, and that's the other piece, I would just ask that they do a follow-up, maybe 4 to 6 weeks, get them back in the office, even if it's just a check-in. If they're not better, they can call. But if they say, I'm either needing the steroid all the time or the steroid isn't enough and I'm getting worse, I think that is absolutely the time to say it's you need to get another opinion. And I would say it's really the same thing for me too. If I see a patient, I'm going to start with the basics, especially if I've never met them before. I'm going to say, why don't we just see? I want to get a sense of your skin. I mean, obviously, if they come in and they have a 200-page chart and have seen 6 other people, we're going to start somewhere else. But many patients say they've used a lot of things, but I really want to say, let me try my regimen. Let's just do it by the book, and then that will really give me a sense of sort of the responsiveness of your disease. Because I mean, I think one of the things we talk about a lot is severity is tricky. You can look bad, but respond really well. And you can look great, but be on cyclosporin and topicals and all this terrible stuff. And you're like, wow, it took like the entire kitchen sink to get them to look pretty good. And I think we need to understand that a little bit better.
I'm going to come back to this case. I want to ask sort of if it's a persistent inadequate control, how we do systemics. But let me pitch the second case first, because this is a 6-year-old who has very impressive atopic dermatitis as you just walk into the room. And when I listen to the history, it's very long standing, since a few months of life. I asked the family a question I always ask: when was the skin last totally clear? And they go, totally clear? I go, yeah, it's like no eczema at all. And, often they can't remember a time period. So protracted eczema has been treated with topical corticosteroids, often on oral antibiotics, and the family's concerned about the long-term side effects of the topical corticosteroids and some of the non-steroids they've used. And then very quickly, we get to the story where they really never have had adequate sleep control. And there's a tremendous amount of sleep disturbance, as well as intermittent infections. So how do you approach that in terms of, do you start back with topicals just so you've done them in your hands? Or when would you consider moving beyond that?
Can I just say that you taught me about that question that you asked, when was the skin last totally clear? And it's one of those incredibly wise questions. It's a little deceptively simple. It's like, oh, that's a reasonable question, but I've never asked it that way until you taught me it. And now that I do, I realize that it also does something that I think we are sort of underrepresent or underdiagnosed. And it's this idea that some patients who are pretty bad, they sort of are just used to it, and they'll sort of automatically downcode themselves. They're like, I'm okay. And they're pretty horrible looking. So by putting it very clearly and to say, literally, when were you clear? I think that kind of benchmarks it, and it kind of puts them back in the real world. So they're like, actually, never, I was 2 months old or something. And that I think is helpful for just sort of getting us kind of on the same page, because we have these severe patients who are so used to struggling and so used to being itchy and miserable that they're like, I'm actually doing pretty well.
Yeah. So I think that's one of the big takeaways, right? Is that I think in this scenario, I'm going to start discussing systemics right up front. If they give me an adequate history that they've used so many grams of a topical steroid over a 2-week period, or so much in a month period, I kind of go, okay, that's impressive. And yet the kid doesn't look controlled. I think right up front, I may discuss how we can get a change in their lives. I think it might be similar for the adolescent too, if they're really persistent and a persistent eczema and inadequate control with the topicals. Peter, do you agree, or do you did something different?
100% agreed. And I think sometimes if the family is nervous about jumping right to a systemic therapy, especially on that first visit, and sometimes they're eager, they're asking me, they brought in the handouts and they're like, can we start it today? But other times they're a little nervous. I'll say, I understand. Let me get you some reading material about it, but I'm seriously thinking about it for you, because and the things that really push me to systemic are, you haven't been clear in so long. I'm worried that you're overusing topical medicines, into the point we're causing trouble, but also just the fact that if there's so much body surface area that it becomes impractical, maybe for a baby for sure. But as we get to the older patients, you're going to be going through pounds and pounds of creams every week. And that just becomes ridiculous. And of course, some of the sensitive areas, it's difficult to treat the scalp. It's difficult to treat sensitive areas on the eyes and in the folds and in the genitals. So some of these patients are just kind of itchy and miserable all over. And I think that's going to push us to go to systemic much more quickly.
I think that when I ask about the impact of the disease, I use that instead of quality of life. It's like, what's the disease impact? But the ways I ask it are ask about itch and sleep disturbance in particular. And then, are there activities or parts of life that have been changed because of the eczema? And if you leave it open like that, and if you give them some time in the room, you'll really get stories of so much workarounds that they have when they have significant atopic derm. Any other considerations you take in, or in terms of the risks and benefits of systemic therapy?
I think there are many, and we're very used to using the old off-label systemic immunosuppressants that had a boatload of potential risks and, a very, very long list of things to go through with the patient. So I really do try to give those things a real fair shake when I talk to the patients. I like them to look at it. I don't want them to be surprised, because I learned early on, if you sort of say, oh, it'll be okay, and then you hand them a sheet, you get a call that night and they say, wait a second, you didn't tell me about cancer risk and infection risk and all that. I will say I'm so happy with the advent of our first biologic in atopic dermatitis. It has been so much easier because it is first of all, it's much better studied in this disease state, but and of course, it's properly indicated for atopic dermatitis instead of being off label, but it also has a pretty compact and manageable set of side effects that I actually think you can do justice to in just 10 minutes. You can sit down and kind of go through them and explain, and that makes it so much easier than something that's, really difficult. How do you really talk about azathioprine in a short visit? It's complicated.
I do agree. Dupilumab as that specific IL-4/13 blockers been incredible, but it's also nice that there's no blood work that's needed at baseline or with continued use. Does make it easier in terms of our discussion with the families. So, Peter, thank you for great words of wisdom that can help us to take care of our patients. And I thank our audience for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.